Good evening, everyone. I am Shreya Kathuria and I work as Assistant Product Manager in Translumina. As everybody is aware, that Translumina is one of the leader in providing cardiovascular solutions in more than 50 plus countries, and it comes under the parent company called Integris Medtech, which also includes Everlife, which is also a leader in providing lab solutions and analytical equipments in South and Southeast Asia. Apart from other these Everlife and Translumina, we are also coming up with many more acquisitions under Integris Medtech. So we are number one player in providing scientific lab solutions, and number two player of and the second largest stent player in India, and number one among the domestic players, with approximately 18% share in coronary stents market in India. We have presence in more than 2,000 plus cath labs and hospitals and 17,000 plus laboratories. We have also distribution partners with more than 350 firms across 60 plus countries. Apart from that, we have manufactured more than 100 SKUs and have 7 manufacturing sites across India and Europe with two R&D centers. Apart from our in-house manufacturing facilities, we have also strategic partnerships with MNCs like Shockwave, Sys Medical, Kanika Corporation from Japan, ASIS, and Asahi Intech. Now, going deep down into Translumina, so we are number one domestic leader among the stents with 18% of market share across India. We have presence in more than 50 plus countries with 5 manufacturing sites across globe, and have acquired three companies over a period of 5 years, which are Lamed, Blue Medical, and Everlife. Moving ahead, with Translumina, we offer a comprehensive cardiovascular portfolio and provide products right from accessing the lesion, which includes our Asahi wires, Kanika microcatheters, and vascular accessories, to assessing the lesion with Assist IVUS and options. We have also a good portfolio for preparing the lesion, which includes IVL therapy from Shockwave Medical, high pressure balloon from OPNNC from Sys Medical. We have our own in-house PTCA balloons as well, which are Optima balloons. And we have also provide a treatment solution for the patient with our stent technology, which includes Yukon Choice, and we have polymer-free stent technology as well, which includes Vivo ISAR and ISAR Summit. Currently, we have also partnered with Medinol and have recently launched a US FDA approved ridaforolimus stent called Elunit Pearl, and we also have a drug coated balloon Protege. Moving ahead, I again welcome all of you to our flagship program called Interventional Insights, where we discuss about how a polymer-free stent technology provides benefits over conventional polymer-coated stents. Moving ahead, this session will be chaired by Dr. Shivnan Ray, who is Director of Cardiology in Fortis, Kolkata. Along with him, we have Dr. Raghav Sharma, who also works as director in RKM Cardiac Care, Ambala. And our chief speaker of the day is Dr. Marco Ferron, who is a attending physician at Interventional Cardiology in Montevergine Clinic, Italy. Along with him, we have case presentations from Dr. Shivanan Ray and Dr. Siddharth Mani from NH Hospital, Kolkata. So we also have in expert panel, we have Dr. Kuldeep from Medicover Aurangabad and Dr. Satish Sawant from Pune Hospital. Our program agenda will start with Dr. Marco Ferron giving us a presentation about real world evidence about how polymer free stent technology is shaping the future of interventional cardiology, followed by case presentation of use of Vivo SR in bifurcation nanocrush technique by Shivnan Ray. And then we'll have a case presentation by Dr. Shivnan Ray, where he used a Nick Nano hydro balloon in uncrossable CTO lesion with polymer-free stent technology. And then we can have a panel discussion where everyone can share their ideas about how Vivo SR or polymer-free technology is benefiting their patients. Over to you, Dr. Marco, for case presentation. Sir, you're on mute. We can't hear you.
Oh, okay. Can you hear me now?
Now
Yes.
yes, we can hear you.
Thank you for the invitation. Thanks everyone for joining this interesting webinar. And I will start with my presentation. Okay, so just a little bit of a glance for who's not familiar with this kind of technology to understand really why and if we need this technology nowadays. We know that DES were the second revolution in interventional cardiology, and we started to use the first generation DES in 2003. We had two family of drug which were used for this technology, which were sirolimus and paclitaxel. And this was actually, we can say today, a pretty rudimental technology, very bulky. We had 132 to 140 microns struct thickness. And this meant that technically we have great issues in deliverability and trackability because the bulky struct thickness and crossability of the device. This brought actually to the development of the second DES generation in 2008. We lost along the way the paclitaxel, and we had all the Limus family drug eluding from this stent. And we actually had three main big family, which were the permanent polymers, the biocompatible polymers, and biodegradable and bioresorbable polymers. The technology had a great improvement in terms of strut thickness, and we had 70 to 90 microns, but still we had some limitation because we had delayed arterial healing, late and very late stent thrombosis, and a need of a dual antiplatelet therapy, which was very tricky in some subset of patients, like the high bleeding risk patients. This is why, along with the development of the second generation DES, we had the development of the polymer-free DES, which Vivo is part of the family. And we're going to have a deep dive into this technology, which is very interesting. And we're going to see why we have big advantages with this stent and with this technology. All the problems and the flow and the limitation we saw in terms of thrombosis and failure of the stent can be attributed to the polymers, which are part of the DES, the second generation DES, and are used actually for the kinetic release of the drugs, which is something very important for the DES. But this actually increases and triggers an aggressive inflammatory reaction, which goes to fibrin deposition, delayed endothelialization, chronic inflammation, and at the end, prothrombogenicity. For this reason, VivoESR was developed as a polymer-free DES, and this is the technology in a glance, actually, a cobalt chromium DES. So the metallic scaffold is made up of cobalt chromium, a microporous surface. We're going to see these in details. And then we have three important components of this stent, which is the sirolimus, the propofol, acting as a drug for the releasing and for the anticyanotic effect, and the shellac resin, which is something which helps to prevent embolization and loss of drugs during the tracking and the inflation of the balloon. We don't know to say how sirolimus work because we all know very well. The propofol actually is a drug which was used past in time as an oral drug for lowering LDL. And it was a drug, actually the only drug, which showed increasing in HDL values, but it was abandoned because it was not as efficient as statins, which then become the most important drug for lipid lowering. But this drug, this previous experience allows us to say it's very safe in terms of safety in humans. And it was used for this stent for facilitating the endothelialization, and most important, for increasing the lipophilicity of the sirolimus, which has a big limitation in terms of release in the vessel wall without this kind of excipient. If we talk about the way this stent without the polymer release the drug, this is the very elegant technology which constitutes this stent. This stent is made up 1 million of pores, micropores per square centimeters with a depth of 2 microns. And this allows to create a micro reservoir of drug, which is saved by the shellac resin. And this gives controlled kinetic of release of sirolimus and propofol, which allows the drug to be released in 28 days. We're going to see this later, up to 80%. So a kinetics which resembles the permanent polymer CDES. And the reason why this stent was developed in this way, so with micropores differently from the other polymer-free DES, which are actually electropolished, is because it was demonstrated the superiority of this technology compared to the electropolished bare metal stent, where we had more restenosis. Another important feature, and this is very intelligent as technology, the micropores, which are directioning actually outwards of the stent, allows a directional drug release, not making the drug, the anti-restenotic drug, in contact with blood flow. So it just targeted the tissue and less systemic exposure of the drug, leading to faster healing, better endothelialization, and reducing the incidence of stent thrombosis. The way the propofol and the sirolimus are released by the stent has been investigated, and the kinetic is actually the same of the permanent polymer-based technology. This is very important when it comes to the restenotic effect. At 80% of the drug is actually released after 28 days under ex vivo conditions. The shellac resin, which is the third component we mentioned before, is not taking part directly to the mechanism of action of the drug and of the stent, but it's very important to prevent the breakups of the matrix, so the propofol and the sirolimus during the stent expansion and during the tracking of the device. These are, in a glance, actually the features of this device. What I want to highlight, which is the very specific feature of this stent, is the great availability with lowest crossing profile. And we're going to see later what we are talking about. When we go down with strut thickness, we have a lot of pros, which is minimal vessel trauma, better conformability, lower stent crossing profile, and faster endothelialization at the cost of less radial strength, decreased visibility, risk of strength fracture. VivoEaser is a DES, very thin, 68 microns for the most of the measure and 79 for the bigger vessel. And the real feature of this device, of this stent, is that we found here a great balance between the pros and the cons when it comes to very thin strut. And we're going to see how. The technical specification are pretty average. We have several diameters and length, with a drug dose of 2.65 micron per square millimeters and a very low crossing profile, which ensures better composability and better trackability of the stent. We have a very robust literature with this stent, demonstrating how safe and efficient it is in several subsets, starting with the animal study, which were conducted by the company for the biocompatibility of the stent. What was shown is that the VivoEaser with no permanent matrix was the one compared to the other one. The other stents investigated was the one with the lowest percentage of stenosis in terms of angiographic results and in terms of histological results, as demonstrated by the histology, even in terms of inflammation. The comparison with the permanent polymer DS showed how VivoEaser gave less inflammation, less fibrin deposition, and better endothelialization. If we want to talk about the clinical impact and the clinical data we have, this is the mainstay study, which was published in 2022 in JACC. This is a very impressive study, a randomized trial with polymer-free sirolimus and probable stents versus zodorolimus. This was the Resolute Integrity, and it enrolled 3,000 patients comparison to one randomization. What was demonstrated in this study is that at 10 years, there is no difference in terms of safety and efficacy between Vivo Ether and the Resolute Integrity Stent. Regarding the composite endpoint of MACE. But most impressive, and this is another publication which was made in a different journal, is if we're gonna see the subset of diabetic patient, the things actually change. We said that the polymer-free DES can improve endothelialization, and in a setting of patient as diabetic patient who have very poor endothelialization and thrombogenicity due to the pathology, what actually shown that for each of the MACE evaluated in this trial, the Vivo Ether performed better than Resolute in terms of MACE. And if we want to see at 10 years what is the difference, we have a statistical difference favoring the polymer-free DES compared to the permanent DES. And the numbers are pretty impressive. Less of 33% myocardial target vessel-related myocardial infarction in the polymer-free, giving us important results and important message, which diabetic patients are high risk patient and needs polymer-free because of all the pathologies which are connected to diabetes. Another important subset where Vivo Ether showed great safety and efficacy was the ACS, where compared to the best-in-class todorolimus stent, showed no differences in terms of MACE at 10 years, giving us a great results, no differences for stable cut, for non-STEMI, and for STEMI at 10 years when compared and randomized to the best-in-class. Absolute stent thrombosis for Vivo Ether at 10 years was 0.9%, pretty impressive results. When it comes to practical features, what I would like to underline is that I think we have three important settings where stents shows how efficient and how performing are, which are the trackability in tortuous anatomies, the bifurcation, and the calcified lesion. We are part of the Secure Global Registry, and we enrolled so far 120 patients almost, and we developed a good experience with this stent. And these are some of the tricky cases we performed with this stent, and this was what I want to show you just to discuss. This is a highly tortuous lesion, very nightmare. So more than 180 twists of the six circumflex arteries with calcification just before the curve. Very tricky for every stent, even the better trackable. This is a 58 lady smoker with hypertension and hypercholesterolemia, stable angina, and this is the lesion we had to treat. So we decided to go with a predilation with a 2.515 millimeters balloon. And then just to make the thing easy, we decided to implant a 32 millimeters Vivo Ether by 3. And I have to say we had no issue to deliver and to track this stent regardless of the grade tortuosity, the proximal tortuosity, with a post-dilation and with the great optimal results. And the second setting is a highly calcified osteal lesion, the RCA. We know these are one of the worst lesions in terms of calcification and in terms of stiffness very hard to dilate, and we need a very high radial stent to treat this kind of lesion. So what we did in this setting, we performed a pre-dilation with a 3 balloon not compliant, and then with a cutting balloon because we didn't reach a satisfying dilation. So we went with a 3 balloon, 3.0 balloon cutting Wolverine, and then we implanted the Vivo ISAR. This is the POT dilation after the deployment at the OSL RCA with a good results. The
I think there's some network issue with Dr. Marco Ferron. I think he got disconnected. We'll try to contact him.
good evening to all. In the meantime, till the time Shreya is trying to reconnect with Dr. Finon, yeah, I think he has already come. Dr.
Hello?
Michael? Yes. Yeah, please.
Yes, we can hear
We
you
can
now.
see you now.
Sorry.
No
So,
problem.
so I'll start where I stopped and everything crashed. Okay. So the next setting I wanted to share is actually bifurcation. This is a bifurcation lesion at the proximal LAD with discrepancy in terms of referent vessel diameter at the proximal and distal part. So we decided to treat this vessel with pre-dilation with a 2.5 balloon, and then the deployment of a Vivo ISAR 3 by 21 DES, and then a subsequent 2.5 for the discrepancies of diameter. And then we went to do a POT pre-dilation of the proximal part. What actually happened is the first diagonal was pinched. So we decided to go for a dilation of the side branch with a kissing balloon. And we had a bad dissection of the ostal diagonal. So we had to implant a second stent, a second Vivo ISAR here with a tap technique. With a great result, angiographic result here. And this is something I wanted to underline for this stent, which is very valuable. We know stent have different patterns. We know we have hybrid cells, closed cells stents. Vivo ISAR has a design very interesting. Once the stent is deployed, once the stent is deployed, it's open. The cell's circumference goes up to 8.5 millimeters, which is 25.7 squared millimeters. And in terms of numbers, is a distance between cells after maximum expansion, which is 5.89. So it's a great trackability for an easy side branch access, which make this stent very desirable for the treatment of bifurcation.
90% damage समझे हाँ
Okay, I think the microphone is open. And the last one is another bifurcation, which is from
okay
this obtuse
okay
marginal.
oh
We pre-dilated the lesion first with a balloon 3 by 15, and then deployed Vivo ISAR with the side branch dilation, and we had a great result. So if we go to the practical feature, I would say this stent has great trackability, great performance in bifurcation, great in calcified lesion, with the pros of lack of polymer, which gives us very confident in terms of late stent thrombosis and great efficacy in most of the setting we use every day in our cath lab. Thank you.
Thank you, sir, for such a wonderful presentations. Like you have covered all the lesions, types of lesions, highly calcified and bifurcations. So it will be great help that the doctors who don't have a good perception about polymer free technology or who are scared to use polymer free technology in bifurcation, highly calcified lesions, these videos and these cases uh, can help us interact with those doctors as well. So we are open for questions.
Thank you, Dr. Marco, for wonderful presentation. I think this is great to have an international speaker coming and talking about his own experience of a polymer-free stent. In India also, sir, we have a good number of experience from clinicians all over the country. In fact, we have a privilege today to have some of the finest, in fact, doctors who have used in these cases, especially with some teachers of teachers like Dr. Shubhanan Ray, sir, or and then Dr. Raghav Sharma, sir, Siddhartha Mani, sir. In fact, sir, we would like to, although they would be speaking now on this, but I would request if Dr. Raghav Sharma, sir, throw some light about his own experience or have some questions from Dr. Marco on basically some of these cases that would really make this discussion much more richer for us during the evening, because a lot of people have joined in. So, sir, may I request you, sir, to seek some opinion on this, sir?
No, definitely, it's an excellent cases and beautifully done, no doubt about that. As far as trackability is concerned, no doubt it's a wonderful stunt and has a very good trackability. Even the balloon expansion is very good if you see, even if you go at high pressures, the stunt opens up and almost it is something what we call as a uniform expansion of the stunt, what we have noticed whenever I've deployed it. I've used in bifurcation or in CTOs also and even long lens. So it's no doubt about that. It has got an excellent open cell design. Side branch protection is excellent. And Dr. Marco, what is your experience like if, let's say, we are dealing in bifurcation and if you have to do mini crush with this or DK crush, what do you think? How do you take it like in such scenarios?
Great experience. I think it's because it's not bulky and you don't have that much, strut crowded. It's not a strut crowded stent. So when you go to crush, you don't have, even if you crush the stent in a bifurcation, you don't have that much of drama to cross the crushed strut. So you can easily go on the side branch and you can create nice new carina if you go with kissing balloon. So my opinion is beyond all the other subsets, the bifurcation, this stent is ideal for bifurcation because has open cells, has good radial force despite the thin strut thickness, but you can easily access the side branch. What we usually did before we had this stent is usually we used the Resolute Onyx, which is the most the stent with the openness cells in alternative to this one. But since we have this one in our cath lab, we tend to use this stent specifically for bifurcation because it's ideal, I would say. So my experience is very good. I've never had a problem, an issue on bifurcation, and I could say it's much easier to recross the side branch even if the strata are crushed for the preparation of a two-stent technique bifurcation. So very positive experience.
Yeah, or you can just do a balloon and leave it also. I think side branch doesn't get much compromise with it. What is your take on that? I think, yeah. Cool.
Agree. I agree. Totally agree. So provisional is our first approach, and we don't have that much of issues on the side branch on the ostium. I just showed that one which dissection of the ostial. It's very rare, but I just wanted to share how the two stents, even when you have to place another stent in the side branch, you have a great results with no problems on crushing technique and creating new carina, but usually you don't have that many issues on the ostial side branch.
Right, right. Sure.
Very nice of you, sir. In fact, Dr. Marco, for sharing this great opinion. And really, Dr. Raghav, sir, thank you very much, in fact, to take this discussion so well. In fact, just on the sideline of these wonderful cases which Dr. Marco has shown, and there are lined up two great speakers coming in now to talk about. And now we would like to invite Dr. Subhanan Ray, sir, especially if he is going to talk on shaping the future with polymer-free, in fact, VivoSR in bifurcation nano crash technique. I think that's something very interesting to learn from especially a teacher like Dr. Shubhanand Ray, sir. Sir, can we have you, sir, for your discussion? It's wonderful having him all the time. It's a pleasure.
Thank you very much for the kind introduction. I need to share my, presentation.
Yeah.
Dr. Marco, can you, if you can remove kindly the presentation so that that sets in the opportunity for Dr. Shubhanan Ray, sir?
Am I still sharing my screen?
Yeah, yes, sir.
Yes.
Yes, sir. Yes, sir.
Wait, I'm gonna exit.
Yeah, thank you, sir. Thank you. Thank you. Now, Dr. Shubhanan Ray, sir, will do that. Thank you very much. Sir, ওটা ঠিক ছিল স্যার আপনি
It's okay. Am I
uh,
visible now?
sir, sir, in fact, your slides are visible, but it should be on
Yeah.
slideshow, sir.
Yeah. Am I audible now? Yes.
Yeah, yes, sir. Perfectly audible, and your slide shows perfectly, sir.
So
Right, sir.
I'm using Vivo ESR for a long time. And actually, this is a case which was done in the initial period, maybe 2-3 years back. And why I was interested about this, we have we are doing nano crash for a long time. And you know that nano crash is one of the, important two-stent strategy in bifurcations, and was tested in lot of with lot of stents. But why I was interested with Vivo is this is a polymer-free stent, as well as, the if you consider the thickness of the polymer and thickness of the starts, and once the polymer is less, the stents becomes more, fine and refined, more refined and more thin. And so they are better, in my opinion, they were better suited for crash stenting, as because during the crash, and particularly though we have a very little amount of metal in nano crash, but still, lesser is better, we know. So with that, we tried whether we can do a nano crash with Vivo ESR stents. And this is a case history. It's a 58-year-old male with a history of hypertension and hypothyroidism. ECG has non-ASTT changes, and with an ejection fraction of 40%. And this is a acute coronary syndrome with non-ST elevation in MI, and after stabilization. So this is the angiogram, and you see that the LED is reasonably okay, and I mean the RCA is reasonably okay. Only there is a Medina 111 bifurcation in the with a large circumflex and the large OM1. So yes, it could be done in a lot of ways, but we thought that as both the branches are large, we would go for a two-stent strategy, and particularly with for nanographs. And planning that, we crossed both the LM and LED with run-through wires, and then we prepared the bed with the NC balloon. Both the branches were prepared beautifully by NC balloon at high pressure at 18 atmosphere, and then kept a 2.5 into 15 NC balloon at 14 atmosphere in the WAM, which was considered as the main branch, and pulled a Vivo ISA 2.25 into 24 in the LCX and which was considered as a side branch. So the Vivo ISA was pulled to the inflated stent, which is just one size smaller than the main artery, and so a part of the Vivo ISA stent is within the main artery and which is going to be crushed. And we deployed the stent at 10 atmosphere, and then we pulled the stent balloon up in the main branch and dilated at a high pressure, 16 atmosphere, and after that and crushed the extra part of the stent which was there in the main branch with the main branch balloon at 20 atmosphere. After that, we came out with the main side branch balloon balloon and stent by balloon and wire. We're keeping the stent there and put a long Vivo ISA 2.75 into 36 in LCX to OM, which is considered as the main branch, and deployed at 11 atmosphere. And then we did the pot with 3.25 into 8 NC balloon at 18 atmosphere, keeping the carina in consideration, and then we crossed the cross to the LCX from the OM and start dilated with a smaller balloon. It's a semi-compliant balloon, LVOHP, and the 1.5 balloon at 16 atmosphere. And then we sequentially post-dilate the side branch, that is the LCX, with and then the main branch with 2.5, 15 and 2 into 12 balloons at high pressure, 15 to 16 atmosphere, and then a final case. And after that, this is the final result. So again, there is a report is done with 3.25 into 15 at 20 atmosphere with excellent stent apposition and restoration of the TMU3 flow. So this is our nanocrush technique, and which was published in Asia Intervention in 2018. And this is the Vivo ISA, because it is a novel stent which is polymer free, and Propofol, which is an anti-cholesterol agent, which are used with anti-cholesterol agent, it acts as a reservoir of the drug, and that is in all studies it is shown it is remarkable stent with good position and good drug effect, and with good restenotic effect, and this is the geometry, which is very comfortable geometry with good side branch access and good rigidity. And so the take home message is both the side branch are more than 2.5, and it is a complex bifurcation with the definition 2 criteria, that is the side branch involvement is more than 10 millimeter, and their two-stent strategy is better perhaps according to the DK Crush study, DK Crush 5. So nano crush technique is a easy, simple procedure with less steps and DK Crush and with excellent long-term outcome. Vivo ESAR is a novel stent without polymer and particularly helpful in complex PCI and bifurcation due to its excellent safety profile. Thank you very much for patient hearing.
Sir, thank you once again very much, sir, for once again a wonderful presentation on this nano crush technique. Sir, although I would request Dr. Marco and Dr. Raghav to have their opinion in the sense on basically the case, because they would be able to, in the absence of Dr. Ravi Gupta, I think they will be able to comment more, but far more better with, because although I do understand that it's a great pristine result as sir brings it all the time. But sir, over to Dr. Raghav and Dr. Marco and Dr. Sawant, all of to have their views and learning points from the teaching points from this while in discussion with sir. Yeah, Dr.
I want to
Marco.
leave the intervention first to Dr. Sharma.
Yeah.
It's a nicely done case, no doubt, and a beautiful result. What we have seen as, I think I was discussing with Dr. Marco earlier also. It's an excellent stent for a bifurcation technique, especially when you're looking at a big side branch. And of course, nano crush beautifully done, all steps beautifully followed, perfect bot. And I think there's nothing much to comment. Everything was so textbook. It's a wonderful case.
I
Good
just
case,
have
sir.
a question for Dr. Ray, because of course, when it comes to bifurcation stance, is the more satisfactory technique. Everything is pretty, neat and clean once you leave to send behind. My question is, how do you forecast, how do you choose how to treat the side branch? I mean, if we look at the side branch, the MO in the angio looked like you didn't have atherosclerosis on the ostium. So my question is, how do you decide when to go for a provisional technique rather than two-stent techniques?
In my opinion, I am not a though I it is my technique. I used this technique years before. I mean years ago. The two stent techniques are really helpful in extremely complex bifurcation techniques. Bifurcations, like as I told you, they my if I do bifurcations 100 cases, 80% is simple bifurcation, and step layered provisional is useful, and I use that in 80% of my bifurcations, be it leftman, be it non-leftman. Particularly in non-leftman, I do not use nowadays two stent. It was done quite a few years ago, when we were doing a study of the nano crush technique in bifurcations. It is a study case. So in practice, particularly in year 2025, non-leftman bifurcations do not, in most of the cases, do not require two stents. This is my strategy. It is almost always a provisional, stepped, layered provisional. And if required, we use maybe kissing balloon, maybe a drug-coated balloon, and very rarely stents. So it is my strategy. But in leftman, and particularly in very large non-leftman bifurcation, where the side branch involvement is more than 10 millimeter, if there is calcification or a very, awkwardly arising side branch, which is very difficult to manipulate with wires, there I usually go from the side branch, and there perhaps my strategy is two stent. Otherwise, I do not use a lot of two stents nowadays.
Thank you very much.
I just want to as sir has rightly mentioned, even Dr. Marco is discussing. The point is, ideally, what I have also believed is you should keep your intervention as simple as possible and as straightforward as possible. See, we're not here to beautify or prove something. What ultimately matters is a good result, a perfect expansion, whether it is a provisional stenting. And usually, I myself is not a very big fan of doing bifurcation stenting, and I prefer lesser the metal rod and better it is. So as you rightly said, sir, so preferably I even prefer more than 95% of my cases to be provisional rather than going in for bifurcation. That's important because you need a long-term antiplatelets also, you need a good amount of statins also, plus at the same time, mostly side branch stents sometimes may not open, and if you see mostly in bifurcation, the side branch stents will be the one will be progressing with the instant restenosis. So I personally feel provisional does give a very good result, and probably now with the development of DCBs and all, it has become much more easier rather than going for like showing something really good. I mean, so that's what I believe. Keeping it simple is the best
Absolutely,
strategy.
absolutely, Raghav. I agree to you, and 100% agree. And also, it is my forecast is it is not very far away that bifurcation in the non-Lichtman at least will be done with 2 DCBs. No stent.
Yes, of course, and in younger population
Absolutely. And
also.
we are doing few cases of only DCBs, and I can tell you they are fantastic.
Yes, no doubt
No
about that.
DAPT after 2 months, after 1 month, and and it is a wonderful result. And it is so
No
simple.
doubt, sir.
And
Mhm.
once you do a bifurcation with a stent, there is always a chance of carina shift. But if you do a bifurcation with a DCB, there is no point of carina shift. It is so easy that you won't believe. You go to one branch dilate, you go to the other branch dilate, come out, finish. 10 minutes, your bifurcation is done. So DCB would be a revolution, I can tell you, in the bifurcation. It is not very far away.
But stand is the stand. It's the first law.
Yeah. No, well, I will like it, especially in some younger subsets where you have simple lesions, you can still consider DCB because long dual antiplatelets is very difficult and challenging, convince patient to take. Absolutely. But stent still remains, as you rightly said, the first option. Yeah.
Thank you, sir. Thank you very much, Swaran sir. It's always a privilege to have you in any of these meetings. I think your experience comes very handy to us. In fact, just to add few points here, in fact, sir, definitely the world is moving towards DCB and a metal-less PCI. In this context, sir, just one thing I wanted to bring to your light to all of you, sir, to very esteemed the experts here, that said what happens as the world is moving towards imaging. In fact, today, in past what you were focused on, basically trackability, deliverability, size of the stent, I think that will not lose its sheen. But with imaging, I think these things have become much more easier for you to actually predict the sizes and all those kind of stuff. But the geometry part, but what is definitely moving towards, the world will move towards, is the vascular biology. How much is the stent respecting the vascular biology, where the role of polymers and the drugs do comes at this point of time. If you look into from the perspective of how much these stents respects the vascular biology, I think the absence of polymer in vivo ISR definitely makes it, as sir brings out the element of probicol, that this basically is a substitute here for the permanent, or for that matter the biodegradable polymer. So therefore, I think this stent is perhaps an inch forward than compared to what we presently have. It may not have that kind of adoption by the Indian doctor still, because of the fact that possibly in our country we still respect the aspect of what we called as some US FDA, non FDA, all those factors, not disrespecting that has its own way of doing things. But at the same time, sir, having somebody like senior people like Dr. Shubhanand sir, or then uh, from other part of the medical fraternity, some respected people like Dr. Raghav sir, and then we have the international speaker Dr. Marco. How do you see in this light of vascular biology the absence of polymer, and especially in this stent, sir?
Actually, stents came as a bailout. Then nobody at that time nobody believed that stent will be over all the places. And actually, the term was stentomania. Nobody, nobody anticipated and expected that there would be a stentomania. And when stents were used in all the places, then came the drug-eluting stents, and nobody cared about whether the stents are safe or not. The stents, we were, quite, uh, apprehensive about the restenotic property of the stents, whether they are anti-restenotic. I mean, but nobody cared whether there is the healing is there. And that then came the studies like basketlate, and the J&J stents were lost. First generation stents were out. Then came the second generation stents. Then came the concept of healing. And the fluorodeoxy which were used in second generation stents like Giants, became the biostable polymers. But still, using a biostable polymer, we have seen that there are stent thrombosis which is in the tune of 0.6%. Now, then came the stent polymer free stents or biodegradable polymers. But still, with the long stents, the data is there is around 3 to 4% restenosis in 10 years. So if the stents are not very safe, still the stents are not very safe. So it would be, again, I think our revolution of PCI is moving towards a stentless or metalless PCI. Stent will be again a bailout. And if it is a bailout stent, always that should be a smaller stent and a polymer free stent maybe, which is easy to heal and safe. Safety is, and we have seen in the long-term studies that after the length of say 30 millimeter, 40 millimeter, every 1 millimeter of the stent counts for restenosis and stent thrombosis. So in the long run, so safety is an issue. So in an era where the DCBs are come in a very big way, stents will be bailout, and stents will be shorter, smaller, smaller in length, and stents should be safe. And they are, they are polymerless PCI, polymerless stents, or innovative newer stents would be beneficial.
Dr. Raghav sir, any thoughts?
Well, I have a little difference of opinion. See, initially, if you remember, when we used to discuss, you used to say there were a lot of aneurysms with sirolimus drug itself. When it was like an era of cipher stent, I would say. So actually, if you go by the fact, it was never the drug which caused the aneurysm. It was the polymer which he used to use. Initially, the polymer which they were using was polymethyl butyl acrylate. It is something which similar what you use in bone cement. Long time when cipher used to. After that, the biopolymers came, as rightly mentioned. They were quite enzymes, which were the second generation stent. After that, we haven't seen much of aneurysm coming from allergic reactions to the vessel, what we used to see earlier. Apart from that, as far as long lens are concerned, see, if you see most of the trials which have been done, even in diabetic patients, stents are not useful. The problem was nobody did a proper post dilatation, and the most of the stents were under expanded at that point of time in that era. So you cannot say that the stents were closing more in diabetic patients, because it is off late by great Dr. Antonio, the concept of high pressure post dilatations came. And subsequently, a lot of imaging we do in the era where people are more into imaging, You see, most of the in-segment stenosis or ISRs are not fully expanded stents or under-deployed stents. So I feel that, of course, DEBs are going to change the future. Still, a lot of data is needed for that, and stents are going to be bailout in near future. But nonetheless, stents will remain because you will need them as a bailout, no doubt, as a first choice in many scenarios. So I think it is a topic which is which can go for an endless discussion, and there is no clear cut idea. It's still a gray area. I would recommend stents or DEBs or DCBs, post dilatations were at high pressure or not, or whatever it is. So probably even in long lens stents, I've seen long lens doing very fine, but you have to have a uniform expansion and very good high pressure post dilatation so that they are well opposed with the vessel wall. Otherwise, even shorter stunts can put you in trouble. That is for sure.
Very interesting perspective from all of you. That's the beauty of doing this kind of educational program. I think that brings a lot of views and thoughts, which helps basically people to learn and from
I
each
think,
other.
Dr. Marco, what is your take on that?
Yeah,
What is your
yeah,
opinion?
Dr. Marco.
All are great thoughts, and I think that generally speaking, stent is pretty much forgiving, in the sense that the data are very safe. Of course, we have niche and subset of patients um, who have more events than others. Where we are moving towards, I think, is the precision medicine. We are starting to use more and more often, even in our practice, genetic tests to see who is resistant to some drugs such as clopidogrel, which in Europe is 30%, who is at higher thrombotic risk. So my opinion is polymer-free is much more physiological stents in terms of endothelialization, in terms of embodiment in the vessel wall. So my idea would be we need to be paying even more attention to the single patient. And where we're going probably is not all the stents are the same for all the patients, but we will have some specific stents for some specific subsets. Because if we look at at the DES permanent polymer, we have pretty much all the same results. And if we compare the polymer free to permanent polymer in the all comers population, it's pretty the same. But if we go in the niche and in the subsets, such as the diabetic patients, then we see that the polymer free is much superior at the long run, 10 years. So what I think is we don't have time. We always are in a rush. So we don't pay attention to these kind of details. But what we should do is let's see the patients, the bleeding risk, the thrombotic risks, and let's choose the best device for the best patient, because not everything is the best choice for everyone. So polymer free is a great technology, is equal to the permanent polymer for most of the people, but is superior for some subset of people. This is where our attention should go to improve our clinical practice in terms of interventionalist. Because otherwise we would treat all the patients at the same, but we have several tools. And when we think to stent, it's not all the stents are the same. Polymer free showed better performance in diabetics, and probably if we go and see, would perform better even patient with higher thrombotic risk, with hemorrhagic diastasis, all these kind of patients who have more events with the permanent polymer. So our attention should go to the specific patient, to specific subset, and to choose the best stent for that patient.
Thank you, Dr. Marco. Thank you very much for your opinion. I think some great opinion coming in. Although respecting time, I would like to go, and then we will have spend some more time, 10 minutes at the end. But before that, let me go to have a privilege to invite the next speaker, and where he's going to talk about the use of Nick Nano balloon in some uncrossable CTA along with a polymer free. I think uncrossable contributes about 4 to 5% of the subset of the population, and in fact, doing CTO of that nature and doing with a stent is a great experience. I would like to invite Dr. Siddhartha Mani sir. I think he needs no introduction. He is a senior intervention cardiologist at Narayan Hirudalaya. Sir is going to speak on this particular topic. So over to you, Dr. Mani.
Yeah. So good evening and thank you for inviting me. First of all, I apologize that I could not reach home yet. So I will be talking from my car only. So can you please share the slides from your end? Yeah.
Yes, I'll share your slides.
Yeah. So honestly speaking, I have used quite a few hundreds now Vivo ISR, because in our hospital, it is a high volume center and we use this stent quite a lot, and really having positive feedback about this polymer free stent. And I have used this in bifurcation, CTOs, long stents, overlapping stents, even in some cases of left main, I mean crossover from LAD to left main, like that. So have good experience with this polymer free stent. Its trackability and everything has been talked about by the previous speakers. So I will straight away go into the case, which was basically a CTO. So next slide, please. It was a 49-year male, a hypertensive patient, and presenting with exertional angina. Next. There were inferior wall ischemia showing in ECG and some moderate LV dysfunction with a 40% ejection fraction, some RWMS present. Angiography was done, it revealed DVD. So in LAD, there was a long segment tubular narrowing with almost 80 to 90% stenosis. And there was a dominant RCA, which was totally occluded in the mid part. And there was some retrograde filling. So our plan, next slide, our plan was to deal with the LAD first and then proceed with the RCA CTO with all my tools. So this was the views, the left and the right views, and we started with the LAD. Next slide. Okay, so LAD was more or less simple. It was, it was the lesser part of the story. So I will just run in through the slides dealing with LAD. It was word with a run-through intermediate, pre-dilated with a 3 millimeter NC balloon. Next slide. And you can see there was a stent deployed, which was a 38 millimeter, 3.5 into 38 millimeter. It was a synergy in LAD, and it was deployed from almost from osteoproximal to the mid LAD, and you can see the final results. Next. Serial post dilatations, of course, and with a 3.5 millimeter balloon. Next. And this was the final outcome of the LAD, which is more or less good, I believe. So we now concentrated on the more important and more complex part, that is the RCA. Next. So RCA, you can see it was a mid RCA CTO and a long segment CTO, because if you look at the left shoot, you can see that the retrograde is coming up to a certain distance, but in between there is quite some distance to be traversed while crossing the CTO. So initially, we as a you can say a protocol, I usually prefer to start with a run through and a microcatheter in such cases, and if my wire is not crossing, then I upgrade to a stiffer wire. So that is what I did here. Next slide. So I tried with a run through and a microcatheter, but it was not crossing. So obviously I had to upgrade it, and I chose a Gaia second wire. Next slide. So with microcatheter support, slowly advancing up to mid RCA, I could cross the Gaia 2 up to the distal segment, and a left retrograde injection ensured that my wire was in the true lumen. Next. Just play it here. Is it playing?
Oh no, sir, it's not playing. The image.
Okay. Okay,
Yeah.
go to the next slide. Somehow it's not playing. So why the videos are not running?
I'll reshare the screen. So I think these are images.
No, these are all videos. These are all videos. You see, there was a play button. It came just below, just now.
So there is no play. I'll reshare the screen.
I'll
reshare.
I checked with Sudeep also while I was giving the presentation.
We can check the.
Can you go to the next slide? Just check.
Yeah. Yes. Yeah, the videos are playing in this slide.
The previous also should have been played. I could not show you. Just try once more if it is going.
No.
Shreya, right click on the video and click on playback.
So I think this is just the image because there is no option coming for playback.
Okay, anyway, it was a video. Anyway, leave it. So basically the thing is, after taking a Gaia, we tried to cross with a 1 millimeter, 1.22 first, and then a 1 millimeter balloon as well, 1 millimeter into 5 millimeter, but it was not crossing. And the catheter was backing out repeatedly. So we took a guideliner support, introduced the guideliner up to the mid RCA because I needed support to push the balloon. But even with the guideliner, the 1 millimeter balloon also was not crossing. So then I took this NIC Nano, and again, this NIC Nano is a very useful tool, I believe. It has helped me in a lot of CTOs. And in many such cases, exactly this same situation happened, that 1 millimeter balloon was even uncrossable. But the NIC Nano has such a beautiful entry profile that it easily crosses in such situations. And I have quite a few, I mean, at least 20, 30 such cases where NIC Nano has helped me to bail out from these situations. So this, I am extremely sorry I could not show you the video, and you could have appreciated that how 1 millimeter balloon was not crossing and everything was backing out. But this NIC Nano, how smoothly it went through. And then I dilated it at higher, almost 16, 18 atmospheric pressures. And then gradually I up titrated with a 1.25 NC and then a 2.5 NC and dilated across the entire length up to almost the crux of the RCA. So then next. This is also not playing. I don't know why this has happened. All of these were videos. I showed all these slides to Sudeep, and he played those also. Anyway, next, check if the next one plays. So then I put a Vivo ISR, two Vivo ISR, in fact, a 3 into 48 millimeter Vivo ISR in the mid RCA. And then the proximal part, there was a go to the next slide.
Yeah.
In the proximal, I took 3.5 into 28 both the stents and had to cover a long segment. And it was, the ostium of RCA was covered, and I also flared it as we routinely do. And ultimately, if you could play the next slide. Post dilated with 3.5 all across the length, particularly at higher pressures in the overlap area. Next. This is the proximal optimization, the flaring done at very high pressures. I usually do up to 22 pressures there. And this is the final result in the RCA. Next slide. So next. So the take home, obviously, choice of wire and microcatheters, and sometimes the guideliner support it is very important in doing such CTO cases, and particular mention about this Nick nano balloon, which is a savior in many such cases of uncrossable CTOs, and obviously proper pre-dilatations and bed preparations, and then this polymer stent covering long segment disease. So ultimately, I was happy with the result and happy with the stent and balloons as well. So thank you for patient hearing, and I'm extremely sorry again some of the videos could not run. So if we can discuss something about this
Thank you
case.
very much, sir. Thank you, sir. In fact, Dr. Mani, sir, in fact, first of all, I'd like to thank you for taking out this time. In fact, irrespective of the fact that you were traveling, you still made such a wonderful presentation, sir. And especially, I think this was a great display of some of the finest tools, especially with Nick Nano. And I know on many occasions you have shared your experience of Nick Nano also. Now, coming to this point of the way you have shown how that especially in RCSR, I was quite amazed with the kind of results, the pristine result which came in this CTO, and especially its usage of this polymer-free stent. I am definitely add a lot of value. Sir, maybe in this case, once again, maybe. Some thoughts in and around Dr. Marco, Dr. Raghav sir, and Dr. Shubhanan Ray sir. If you can add some of your thoughts, how the aspects of the aesthetic aspects and the kind of the tools which have been used in these cases. And sir, maybe your expert's opinion, sir.
It's a nicely done case, no doubt about that. And I must say that, first of all, congratulate you for doing it so smoothly. And of course, yes, guide wire does make a difference. And if you have an extension catheter, as he has used, should be used boldly. And I think the results are perfectly fine. It's such a long segment CTO and going into the true lumen and doing it so beautiful. I think nothing much. It's a perfectly done case, actually.
Thank
Congratulations for the case. It's great results. I have a question. This is just a question about the approach to the CTO. Once you realize the filter will not cross the lesion, my question is, do you use to try to navigate microchannels with a filter, or you usually go with drilling, with a Gaia, with a penetrating guide wire? And why did you choose Gaia rather than, microchannel navigation?
Yeah. So basically, what I do is, if I find even a very narrow micro channel, I mean, sometimes we find a thread-like micro channel connecting the proximal and the distal segments. So there, I believe that, if I use filter, it will be a better trackable lesions. Better trackable. But in cases where it is totally cut off and I don't find any particular channel visible, and also sometimes while, as I said, I usually start with run through or a workhorse wire, and then I try to have a feel of the lesion, because if it really feels very hard, and if at the very entry point my workhorse wire or the run through is bending, so it's buckling, so I find that it will be very hard. So in that situations, I sometimes directly go to Gaia 2 or even Gaia 3 in certain cases. Usually that is, I don't have a very fixed protocol for that, but usually the feel of the wire and some visible micro channel is what guides me in selecting my next wire.
I just want to ask you a simple question, Dr. Siddharth, as Marco has beautifully asked you. So what is your basic technique of maneuvering a wire across a CTO? I mean, are you using some kind of a micro catheter? Even for that matter, if you're using Fielder FC or XT for a micro channel, you do need some support, or you use OTW over the balloon, over the wire balloon technique to cross it. So what exactly do you do?
Micro catheter. It's always a micro catheter. Here also we took a fine cross. I could not show you the clippings properly. So micro catheter I usually always take, because in any case we may have to exchange the wire. Even if we cross, we try to push the micro catheter across the CTO segment and try to exchange it.
So did you try
We
to, I mean, did you try to take that fine cross or across the CTO part or not? Because
Yeah,
just
yeah. I tried. Yes, and that is what we always do. I tried. The micro catheter did not go. Then I took a 1.2 balloon. That did not go. Then I believe that 1x5, the smallest size balloon, I mean NC will track, but that also did not go.
see, did you try to
So
change your micro catheter to Caravel? Maybe that could have helped you because it's a little more fine, more maneuverable and easy to cross.
that could have been done, but I mean, as I said, that I have a good faith or confidence, you can say, on this Nick Nano balloon, because in such situations I have faced quite a number of times that the micro catheter is not crossing and 1 millimeter not crossing. So I thought ki rather than wasting my, I mean, opening another Caravel will cost the patient also, and maybe I will fail again. So then I will again have to open a Nick Nano. So whenever I attempt such CTO cases, I always keep Nick Nano handy at my bedside. And somehow I was feeling this lesion was very much tough and it was absolutely non-crossable. So I decided to go for Nick Nano only. Maybe your option of taking a Caravel and trying with a Caravel could have worked. I accept.
Post Nick Nano, did you even think of like exchanging your wire? Because see, what the biggest challenge is, sometimes what happens is when you leave the wires, you may end up perforating a side branch, especially with Gaia 2. That's the problem, because
But
sometimes
because
when
the
you're crossing
micro
the hard
catheter
line, you
did
don't
not
get a control.
go, yeah,
After
I had
balloon
no
dilatation.
option.
Yeah, after
Oh,
balloon
after the
dilatation.
balloon dilatation. Yeah. After the balloon dilatation, I mean, after that 2.5 balloon dilatation, it was, everything was seemingly smooth. So I was careful about not to push my wire too much distal. So I had to again, I mean, already I was doing the case for a long time. I mean, I thought next steps will not be too much tough. So I did not exchange the wire. But yes, obviously, if you go by the theoretical steps, I should have again recrossed and I mean, changed the wire with a softer wire. That would have been safer, no doubt.
Can I make a point here? The
Yes, sir.
point is, yes, Caravel is not very pushable. Caravel is mainly for the retrogrades. It is better to have a turnpike LP so that it has got a more strong blade and you can move around, you can rotate it. And this is number one. And in many of the situations where the fine cross is not moving, nowadays a new fine cross has come with a good body and it is an excellent catheter. And I don't know whether you have a chance to use it. The
No, I haven't,
new
sir. I haven't.
Yes, the new fine cross, it has got a wonderful body and it is a good trackable, very trackable, and hydrophilic with the proper hydrophilic coating, and it can cross the lesions very nicely. So I mean, the micro catheters are every day getting refined, and newer catheters are much better. So
Improving, yes.
I think new fine cross can be used in most of the cases, I believe.
And
Sure,
one more
sir.
point
I
I
will
just want
definitely
to
try.
say
Yeah.
that is, you sir, sorry to interrupt you. The point is, even when you're, I think Marco will also agree with me on this. If you're taking a micro catheter, you never push a micro catheter in a CT. You try to torque it or milk it through the wire so that it can easily, it's kind of a screwing mechanism. It crosses. So that is what you don't directly push it. The moment you're going to push it, everything's going to back.
Exactly.
Yeah, that's the
True.
point. So what I
Yes,
said, while you enable.
Caravel sometimes is more trackable to through such lesions, maybe.
No, definitely it is good for tortuous vessels, no doubt about that. But Caravel does have a hydrophilic coating above it, and if you milk it through the wire, sometimes you are easily able to cross it rather than pushing it directly. Yeah.
Okay. Yes.
Thank you, sir. In fact, a wonderful presentation. We had three very nice presentation from Dr. Marco, and then from Dr. Shivanand sir, and then Dr. Siddharth Mani sir. And I think the points were very well taken. I think there was a great display of the tools, especially right from the CTO tools, and at the same time talking about the usage of a polymer-free drug-eluting stent. I think uh, that's a great point. I would now basically come to an end. In fact, uh, uh, with only with the thoughts which I wanted to leave all of you today was with the thoughts that today polymer-free deaths. Especially with the kind of data which has emerged for Vivo ISAR. In fact, during the last TCT, in fact, we had some of the finest animal studies, GLP studies, which clearly went on to show that when we try to compare polymer-free DES and compare with polymer-based drug-eluting stent, in fact, the rate of endothelialization at the 7 days, 24 days, and 90 days has been slightly superior in terms of vascular healing process, or for that matter, the endothelialization process. In fact, somewhere it has been now observed that polymer free definitely contributes towards a better endothelialization, because these polymers are sometimes are the nidus for various kind of inflammatory process. So it definitely, especially what Dr. Marco brought, that there are some subset of patients, especially diabetes and patients with bleeding risk, definitely DEB would be the choice in times to come. But when it comes to drug-eluting stent, polymer free would be the choice, because for especially for this subset patients, and especially to bring certain point home, if you look into today's world, there is 21% of the population in the whole world is getting aging. And in fact, in aging population, bleeding risk is one of the most important factor, and polymer contributes towards it. Look into the diabetes. It's a kind of an epidemic worldwide. Globally, I think 30 to 40% is the basically is the kind of occurrence rate. Now, in this patient also, we have a diffuse lesion, longer lesion, especially in this kind of patient. Again, they are more prone towards the bleeding risk and various other challenges. I think in this kind of scenario, clearly what emerges is a kind of a safer drug-eluting stent. And I think in this shade of light, I think Vivo ISAR clearly comes out as a choice, because this is one stent which have been studied in diabetic patients, not only for 1-2 years, for 10 years, and they have been compared with the Zetralomus, and they have been found to be equally effective, because these trials were never designed for superiority. Therefore, we do not know, it could have been superior also. But at this point of time, the trend showed that numerically it was better. So therefore, it clearly showed on that aspect. Having said this, I think I would only request through this forum that if we can extend the benefit of this drug-eluting stent to larger subset of population and patients. With this thought, I would like this opportunity on behalf of my entire team and Translumina to thank you very much for contributing towards it. If any thoughts, otherwise we can sign off for this evening. Thank you, sir. Thank you very much. Thank you, Cho. Thank you. Bye-bye, and have a great evening going forward.